in the group. Well, now that we have some handle on we have biomarkers for disease activity at least. Can you use those to improve your therapy? There's two kinds of treatment for OMS if we're going to paint the broad strokes. One I call neurotherapy, and that's what you do to actually improve brain function. You're not trying to get at the problem, the root cause. You're trying to just help the brain function better. The other type of therapy is immunotherapy, where you're targeting the immune system and trying to get it to regulate itself again and try to get the cells to learn tolerance. Now, the immune system is educatable, and over the years that this is going on, the immune system is developing just as much as the brain in these children. So that is a goal, is to try to make it function normally down the line. Now, in terms of neuromodulation, what am I talking about? Well, ACTH and steroids that are frequently used for the syndrome do change brain function. They're getting into the brain and modulating function. In terms of symptomatic therapy, as many as a third of the children with OMS have ADD, and they respond to treatment for ADD, stimulant medications. A significant number have a sleep disorder. They respond very nicely to trazodone for the sleep disorder. Many of them have rage attacks that tear up the house, that responds nicely to risperidone. So symptomatic therapies help kind of normalize things while we're working on the immune system. In terms of the immunotherapy that's available, you can just cause immunomodulation, meaning you don't kill any cells, but you modulate their activity. You generally suppress them. Or I can use cytotoxic agents that kill cells. That's what they do. I can prevent infection because I know that infection causes relapse. So IVIG helps prevent infection. So that's another kind of approach. And I can remove antibodies through plasmapheresis or plasma exchange. The problem is that's a fairly big undertaking in a toddler, and it's not benign. So, and the other thing is we don't know what the antibody is. There's not been one antibody found in all the children, so that's not too appealing. I already told you that one. So let's talk about some specific agents. There's a controversy about whether you should use ACTH, which is corticotropin, or corticosteroids, and Kinsborn in 1962 actually was the first one to report that ACTH is effective. In our hands, ACTH is superior to steroids, but there are many centers now who use one or the other, and they're locked into that. Another approach is chemotherapy, and there are trials now of using Cytoxan in combination with other agents for OMS, even if you have low-stage neuroblastoma. That ordinarily wouldn't be done. So that is something that's being tested. But I mentioned that we were rather disappointed in the results of cancer chemotherapy in getting rid of the immunologic problem here. One can use Imuran. We introduced Cellcept, a newer version of Imuran, basically, that came out of the renal transplant literature. And it's very good, particularly at preventing T-cell activation and proliferation. I mentioned plasmapheresis. You can be fancy and add an extra column that has staphylococcal bacteria protein on it that the antibodies stick to, and you can really remove a lot of IgG through the use of that column. And the next category is a very exciting one, monoclonal antibody therapy. So again, we want to take down the immune system as selectively as we can. We don't want to make the person immunocompromised. We're looking for the immunological magic bullet. Okay. Rituximab is, you heard that mentioned earlier too, is one that's under evaluation at our center. We just got a grant from Genentech for a phase 1 clinical trial, and shortly we will be able to offer the product and all the tests that go with it free to participating families. This is not something off the shelf. It's been approved since 1997 for lymphoma, B-cell lymphoma, and more importantly, it's been used in children for other autoimmune disorders. It's given intravenously. There's different protocols, but usually the treatment is given over a 1-month period of time, and you can give booster injections later on, and the effects last at least 6 months, maybe 12 months, maybe longer. It's not been studied out beyond that point. Here's the striking findings. This is in one child who started out with almost 4% B cells. 6 months after treatment, they're gone. And not only are they gone, the CD20 positive B cells, the mature B cells are gone, and the CD5 positive population, it's a specific subgroup of B cells that like to cause autoimmune disease, they're gone. Clinically, what happened was she was on the borderline between moderate and severe, at the top of moderate, and she had about a 40% reduction in clinical severity. This is going to come out this year in pediatrics, just in press, plus a lot more detail than I can show you here. Let's show you what she was like here. She has the opsoclonus or ocular flutter.
What color is Mr. Spider? What color that is? Purple.
And it's difficult for her even to stand. She doesn't want to do it at all. You can see with the use of these blocks again that she's got some dysmetria. The block keeps skidding over the one below it. Even when held by the arm, by her mother, her gait is very abnormal. So 3 months after the last infusion, we're not seeing opsoclonus anymore. A lot of the kids try to thwart us by engineering something horizontally rather than building a tower, but at least now she can get some of the blocks to stay on, and she can take independent steps. Still a toe walker, but so 9 months out, her eyes remain very calm.
What is this? Tell me. Is it on top of the other? It's like a tower.
We're back to the blocks.
But you have still 4. Going pretty high. You can't do 4. Oh, what about 5?
By the time you're discharged from our clinic, you can stack 8 out of 8.
Yeah.
Hey, she did it. Now she can run. So she received no other immunotherapy. What's really important about this case is she received no other immunotherapy, no ACTH, no steroids, nothing. So this was all done by taking out the B cells and whatever cascade effect taking out the B cells might have had on other cells.